To provide insight on the COVID-19 situation in the country, I'm joined by Dr. Githinji Gitahi, who is the Group CEO of Amref. I beg your pardon, Amref Health Africa. Good to have you with us, Dr. and good to see you looking well.
Thank you.
So just going off that report by Rose Wangui, what's your position on the mixing of vaccines? I know Thailand has been vaccinating its population with the Chinese vaccine. Is it Sinovac?
Sinovac.
But they've been bolstering it with the AstraZeneca vaccine. What's your position on that?
Well, my position is that science is progressive. And I think for now, we know very well that the protocols that have been tested and approved say that you stick with one vaccine within a schedule that's advised. And that schedule, even now as we speak, is changing. You know, you have sometimes saying, originally when we started giving AstraZeneca, it was 8 weeks. Then science showed 12 weeks is better. And now we have science showing 16 weeks is even better. So science is progressive. So the conversation around mix and match is also progressive science. So we have data showing that if you mix AstraZeneca and Pfizer, you could actually end up with a much better immune response. So all this is progressive. The question is, what is our focus right now? Our focus right now is to get as many people as possible with some optimal protection against COVID. So if we start mixing this with mix and match, then we are going to start getting people saying, I took AstraZeneca, so I'm not taking a second one, even if it's available. I'll wait for Pfizer. Then you start getting risk because we know that one dose is not adequate, 2 doses are adequate. So this is ongoing. We don't have adequate data for policy change. There's a difference between research data and policy change. Research data is continuing until it's absolute, and then you can have a policy change. For now, we do not have policy change from WHO, even from the government, saying that from now on we'll mix and match. For now, we stick to the schedules that are advised: 2 doses of AstraZeneca, 2 doses of Pfizer, 1 dose of J&J. When science is adequate and policy changes, we can then move to mix and match.
All right. So part of which is exactly what the Ministry of Health provided as guidance this afternoon from Harambee House. They also encouraged teachers to get vaccinated because there is a concern there where schools are concerned. And countries such as the US are offering incentives. Biden, for instance, has called on governors to offer, for instance, $100 for people to get vaccinated. Do you think perhaps we should adopt a similar policy?
You see, the challenge we have, Olive, is that we don't have vaccines for the high risk. The challenge that the rich countries are having is we have so many vaccines, we want to offer them to people who are low risk, and we even want to incentivize them to take them. This is the morality dilemma that we have. That actually, when you look at global solidarity, we should be looking at the world as if it's one. And we should be looking at every life has equal value, which means that a high-risk individual in Kenya, in Malawi, in Chad, has the same value as a high-risk individual in the US or Europe. And therefore, when we actually say that we do not have vaccines for high-risk individuals in Africa, but we are giving incentives for low-risk individuals to take vaccines, it is a morality question. And that's actually an issue of justice. So we are calling this, and we are actually calling it out as discrimination, vaccine apartheid, and we are saying that everybody in the world should be focused on, can we provide vaccines to high-risk individuals, the elderly, people with comorbidities, hypertension and diabetes, cancer, HIV, who have higher risk, and that should be our focus. So this thing of incentivizing low-risk individuals is actually a failure of the global justice system.
Okay. I thought that was the whole purpose of COVAX, where all these countries come together and are able to obtain vaccines in a unified fashion. But what we've been seeing is, I know the US has said they will donate, if I'm not mistaken, about 1 million doses of the Pfizer vaccine. I stand to be corrected. And the UK tomorrow, if I'm not mistaken, will be donating about 800,000 vaccines to the country. So are you saying that model is not working?
So this is what is going on. Number one is that COVAX was created as a mechanism. COVAX does not manufacture vaccines. COVAX was created as a mechanism to create what we call advanced market commitment. Because the vaccines are being manufactured and the companies manufacturing are manufacturing for particular orders. So, people have booked about 11 billion doses are committed globally to be produced. Out of those 11 billion, only 900 million are available for sale. Can you imagine? The rest have been committed in advance by rich countries, meaning that COVAX is actually struggling to find vaccines to actually distribute to countries that we call COVAX eligible, which are the same countries that receive childhood vaccines from Gavi, from the Global Vaccine Alliance. So the challenge of COVAX is access to vaccines. The money is available. COVAX has raised money from rich countries, but the rich countries have given COVAX money to buy vaccines, but not release the ones they are holding. So COVAX has no vaccines to buy. This is the challenge that we are facing, and the call out is that if we have to vaccinate countries, the rich countries have to release doses which they are holding for low-risk individuals. As you asked earlier, countries are giving people $100 to accept a vaccine. They are low risk, but COVAX is empty, waiting to receive doses to distribute to poor countries. Where is the logic in that? This is the challenge. So the COVAX is a mechanism, but there are no doses for COVAX to distribute.
All right.
Yeah.
Okay, I want us to take another story and so that we can get into the COVID mitigation measures